Welcome to the Deep Dive. This is where we take something complex, pull it apart, and find the really fascinating bits just for you.
Think of it as your shortcut, getting you up to speed without you having to read, entire textbooks.
Exactly. And today we are plunging into the world of technical and rebreather diving. Deep stuff.
Yeah, we're looking at the specific health issues these divers face. Our guide is the textbook Hyperbaric Medicine Practice. Really authoritative stuff.
Right, so you're curious about this. Maybe you've heard bits and pieces, but who has time for dense medical texts?
We get it. So this deep dive, it's your fast track to understanding the unique risks.
Our mission is simple. Pull out the key info, make it clear, maybe find a few surprises along the way.
So starting with the basics then, what makes technical diving different from, say, regular SQB?
Good question. Fundamentally, it's about going beyond the limits of recreational diving.
Right, so deeper dives, longer time spent at depth, sometimes needing mandatory stops on the way up, decompression stops.
And often using different gas mixtures, not just air.
Exactly. Divers have always looked for ways to stay down longer, right? Trying to get around the physics, Henry's law, how gas dissolves under pressure.
Like opening a soda bottle, that idea.
Yeah.
More pressure, more fizz dissolved.
Kind of, yeah. More pressure underwater, more gas dissolves in your body. Technical divers are managing that very carefully.
So they use different gases, maybe helium, nitrox.
Precisely. Multiple tanks, complex decompression plans, often dive computers running sophisticated algorithms. It requires a lot more training, more gear.
And rebreathers fit in here. They're a key piece of tech gear, I gather.
Oh, absolutely. Big difference from standard SQB where you just, breathe out bubbles.
Right, open circuit.
Yeah. Rebreathers recycle your breath. You breathe into and out of this bag, a counter lung.
Yeah.
Your exhaled breath goes through a chemical scrubber, takes out the CO2. Then the system adds back just the oxygen you used up.
So less gas wasted.
Exactly. Huge advantage. You carry less bulky gas, potentially less decompression needed because the oxygen level is optimized, and the air you breathe is warm and moist.
That sounds much nicer than cold, dry tank air.
It really is. A big comfort factor on long, deep dives.
So are there different kinds of rebreathers?
Yep, 3 main types. Oxygen rebreathers, they're very simple, just pure O2, but super shallow limit, like 20 feet, because of oxygen toxicity risks.
Okay, not for deep stuff then.
No. Then you have semi-closed circuit, SCRs. They use one gas mix and add bits of it to the loop.
And the third type?
Closed circuit rebreathers, CCRs. These are the most common in technical diving. They use 2 gases, pure oxygen, and a diluent gas that's usually air or trimix, which is oxygen, helium, and nitrogen.
And CCRs are the ones that give divers that real edge for deep, long dives.
Yes, definitely. Because they maintain a constant partial pressure of oxygen PO2 no matter the depth.
Why is that constant PO2 so important?
It's key for decompression. It lets you optimize, minimize how much inert gas like nitrogen or helium builds up in your tissues.
Wow.
And it avoids getting too much oxygen or too little.
So how do they do that? How do they keep it constant?
They use oxygen sensors inside the breathing loop. Little electrochemical cells, usually, that measure the PO2.
Like a gauge?
Sort of, yeah. They send a signal to the rebreather's computer. Some newer ones use luminescent dyes, like Poseidon units.
And accuracy is critical, I assume?
Absolutely vital. The computer uses that PO2 reading to calculate your decompression, tells the system when to add oxygen, get it wrong, and you risk hypoxia, not enough O2, or hyperoxia, too much O2. Both are bad news.
Can things affect the sensors, like temperature?
Yeah, temperature, humidity, they can throw off the readings. That's why calibration before diving is non-negotiable.
Makes sense.
Yeah.
You also mentioned something called SLLD, static lung load differential.
Yeah. That's about the work of breathing. Depending on where the counter lungs, those breathing bags are placed, it can be easier or harder to inhale and exhale.
So some designs are easier to breathe than others.
Essentially, yes. Different designs, over the shoulder, back mounted, positive pressure, negative pressure. They all feel a bit different. It affects comfort, especially on long dives. A detail, but an important one for the diver.
Okay, good background. Now let's get into the specific health issues. You mentioned fatigue. How is it different for tech divers?
Well, any dive can make you tired, right? But tech dives are often much longer, maybe more physically demanding, so there's that.
Who's plain worn out?
Yeah, but also breathing higher oxygen levels for longer puts oxidative stress on the body. That can
Not sedative stress, like rusting from the inside.
Sort of a rough analogy, but yeah. Plus, even a mild subclinical DCS, decompression sickness you don't really notice symptoms for, can just present as feeling wiped out.
Interesting.
And don't forget heat loss. You lose heat way faster in water, even warm water. Your body works hard to stay warm. And then there's a fluid shift after the dive, pressure immersion diuresis, which drops your central blood volume. All adds up.
So the key is recognizing when it's not just normal tiredness.
Exactly. Unusual fatigue needs attention. Could be DCS, hydration, rest, maybe even supplemental O2 are things to consider post-dive.
Okay. What about hyperoxic myopia? Oxygen eye? Sounds weird.
It is a strange one. It's basically temporary nearsightedness.
You get nearsighted from diving.
Potentially, yeah. Mostly seen in rebreather divers doing long, multi-day missions running high PO2s like 1.3 atmospheres or more.
Why run the oxygen so high?
To reduce the decompression time, less inert gas loading. But the downside can be this vision change.
How does it happen?
The theory is the prolonged high oxygen affects the lens itself, changes its shape or metabolism somehow, making you temporarily myopic.
Wow. Is it permanent?
No, thankfully. It's reversible. Once you're back breathing normal air, vision usually recovers. Might take days, sometimes weeks, even months, though.
So you shouldn't dive until it's back to normal.
Definitely not. There's a similar thing seen in people getting hyperbaric oxygen therapy in chambers, but sometimes that takes even longer to resolve, and there's a very rare link to cataracts.
It really shows how gases affect everything, even your eyes.
It does. Every tissue responds to pressure and gas changes over time.
Then there's off-gassing in the eyes, particularly for contact lens wearers.
Yeah, this is different. It's blurred vision, maybe seeing halos around lights after deep or deco dives. Mostly affects people wearing hard contact lenses.
Why hard lenses?
The idea is that inert gas, maybe nitrogen, comes out of solution in the fluids behind the hard lens, creates tiny bubbles that mess with your vision.
Like little bubbles trapped there.
Exactly. Soft lenses seem okay, probably because they let gas pass through more easily. The eye tissues off-gas fast, but the gas gets stuck behind the less permeable hard lens.
What's the fix? Just take them out.
Usually, yeah. Removing the lenses helps. Some people get a tiny hole, a fenestration, drilled in the lens to let gas escape.
Okay, now caustic cocktail. That does not sound good.
It's really not. It's what happens if water gets into the rebreather scrubber canister and mixes with the CO2 absorbent.
The stuff that takes out the carbon dioxide.
Right. Usually soda lime, mostly calcium hydroxide with some sodium or potassium hydroxide as catalysts. Very alkaline, high pH, like over 12.
Highly corrosive then.
Extremely. And the reaction with water creates heat too. Normally it just neutralizes the carbonic acid from your breath. But if water floods in,
You get this slurry in your breathing loop.
yeah, a caustic slurry. It's a serious potential hazard. Really drives home why checking gear meticulously is so important.
What happens if a diver actually breathes or swallows some?
It's nasty. Ingesting it. Severe sore throat, pain swallowing, nausea, vomiting, stomach pain. Inhaling it as a mist is even worse.
How so?
Airway swelling, chemical burns in the lungs, liquefactive necrosis, which is tissue dissolving, basically, chemical pneumonitis, maybe full-blown ARDS requiring a ventilator. It's bad.
What's the first aid in the water?
Get upright, controlled ascent. Rinse the mouth with fresh water if possible. Encourage swallowing to try and clear the throat. Don't make them vomit. No weak acids either, could make it worse.
And prevention.
Pre-dive checks are key. Negative pressure test, make sure the loop is sealed against water entry. And never take the mouthpiece out with the unit switched on.
Okay. Hypercapnia, too much CO2?
Yeah.
That can happen even on open circuit, right?
It can, yeah. Skip breathing, working too hard. But rebreathers have unique failure modes related to the scrubber.
Like what?
If the absorbent isn't packed right, you can get channeling. The gas just finds a path through without getting scrubbed.
So the CO2 goes right past the absorbent.
Exactly. Or if you don't fill it enough, or if it settles. Packing technique is critical, tapping it down using anti-channeling pads if supplied.
And the absorbent just gets used up eventually.
Right, that's called breakthrough, when it can't absorb any more CO2. Interestingly, it often happens at the edges first because the center stays warmer from the chemical reaction.
So CO2 starts building up in the loop. The diver is rebreathing.
Yes, and there's nowhere for it to go. There's also this weird thing called the Dean effect or pneumogastric ventilation.
What's that?
CO2 produced in your stomach, like after a big meal or fizzy drinks, can actually get into the breathing loop.
Seriously?
Yeah. So if your scrubber is already failing, that extra CO2 from your gut makes things worse faster.
What are the symptoms of hypercapnia?
Early on, maybe a headache, feeling confused, tired. But it can get bad quickly. Disorientation, panic, feeling like you can't get enough air even though you're breathing, convulsions, passing out.
And the urge to breathe gets really strong.
Intense. That's a huge danger if you panic and switch to your bailout tank. You might just suck it dry incredibly fast trying to satisfy that air hunger. Prevention is all about scrubber maintenance. Fresh absorbent packed right, respecting duration limits.
Got it. What about oxygen ear? Is that like regular ear squeeze?
Not quite. It's related to pressure, but different. Happens after long dives on high oxygen levels. The high PO2 gas in your middle ear gets slowly absorbed by the tissues. Normally, your eustachian tube opens, lets more air in, keeps the pressure equal.
But if it doesn't open enough,
Then the absorption creates a negative pressure, pulling the eardrum inward. Feels like fullness, maybe mild hearing loss, like having a cold. Usually painless, often noticed the next morning.
like serous otitis media, fluid behind the drums.
Similar effect, yeah. Acute serous otitis media. Treatment is usually simple, just equalize your ears gently, repeatedly, to get air back in there.
But it's important to know it's not barotrauma or worse, inner ear DCS.
Exactly. Especially for tech divers who have those other risks. Gotta differentiate.
Okay, pulmonary oxygen toxicity, the Lorraine-Smith effect. This is damage to the lungs from too much O2 over time.
Yes, less immediate than CNS toxicity, the brain kind, but a concern on very long dives, saturation dives, or repeated high FiO2 technical dives or chamber treatments.
So rebreather divers running high set points or tech divers may be miscalculating gas exposures.
Those are the scenarios, yeah. Early signs can be subtle, a little cough, irritation in the windpipe, maybe worse when you breathe deep.
Then it gets worse.
If exposure continues, yeah. Chest tightness, maybe pain behind the sternum, eventually shortness of breath, even without exertion.
Does it depend on the O2 level and time?
Definitely. Higher PO2, shorter time needed for symptoms, but people vary a lot in susceptibility. You might hear crackles in the lungs, see changes on X-ray eventually.
How do they track the risk?
One way is measuring vital capacity, how much air you can blow out. Small drops are reversible. A 10% drop is often considered the limit for safe HBO exposure.
And there are tracking units, UPTD or OTU.
Right. Unit pulmonary toxic dose or oxygen tolerance unit. Ways to quantify the exposure based on PO2 and time. There are guidelines like trying to stay under 300 UPTD in 24 hours for multi-day diving.
Makes sense. Now, pulmonary disease. Is that about infections from the rebreather itself? The loop sounds like a good place for bugs to grow.
It definitely is. Warm, dark, moist, perfect incubator. There are anecdotal reports, divers getting recurring coughs or respiratory crud.
And the suspicion is contaminated gear.
Yeah. Improper cleaning, maybe sharing mouthpieces without disinfecting. There aren't universal standards, but manufacturers give cleaning guidelines and you really need to follow them.
Have studies looked at disinfectants?
A few, yeah. An older one suggested Virkon S or Trigene II were okay. A more recent one found stearamine and Listerine might be even better.
Stirring. How do you use that?
The best way seems to be flood application. Rinse the loop, fill it completely with the stearamine solution, let it sit for maybe 10 minutes, then rinse thoroughly again. That study showed it basically wiped out bacteria.
And this should be done after every dive?
Ideally, yes. Choosing a cleaner involves balancing effectiveness, health risks to the diver, and whether it might damage the equipment materials. But flooding seems the most effective cleaning method.
Hypoxia, lack of oxygen. Obviously critical. How does it happen specifically in tech diving?
With rebreathers, it could be the O2 addition failing, electronics messing up, maybe not flushing the loop properly with a breathable gas at the start.
Or just not enough gas flow if you're working really hard.
Exactly. Physiologically, maybe impaired gas exchange at depth or breathing dense gas mixtures makes it harder to ventilate properly. Helium mixes can cool the lungs too, might affect gas transfer.
And mistakes with open circuit tanks.
Big one. Grabbing a hypoxic trimix cylinder meant for 300 feet and breathing it near the surface. Instant blackout potential.
Because the partial pressure of oxygen is way too low at shallow depth.
Right. Remember, rebreathers work best underwater because the pressure boosts the PO2. The biggest risk is often near the surface, especially working hard.
What are the signs?
Can be subtle at first, poor coordination, dizziness, can't focus,
Yeah.
then confusion, convulsions. Death follows quickly if O2 isn't restored. Symptoms start around 0.16 PO2, definite hypoxia at 0.14, lights out around 0.10.
Treatment is oxygen, obviously, but prevention is the real key.
Absolutely. Meticulous checks, analyzing every gas, proper labeling, avoid busting your gut near the surface on the loop.
Okay. Deep water blackout. That sounds related to narcosis.
It is. It's basically passing out from extreme nitrogen narcosis at serious depth, like deeper than 220 feet or so.
Different from shallow water blackout and free diving.
Totally different, yeah. DWB is narcosis. And rebreather divers could, theoretically, be more susceptible if their scrubber fails.
Because the CO2 buildup makes the narcosis worse.
Right, that super narcosis effect. People used to dive deep on air, which was asking for trouble high PO2 and crippling narcosis.
But now it's helium mixes below, what, 150 feet?
Generally, yeah. To manage both narcosis and oxygen exposure, DWB symptoms are just severe narcosis tipping over into unconsciousness. Prevention is all about dive planning, sticking to your depth limit, and minding that scrubber.
Isobaric counterdiffusion, ICD. You said it's not a malady itself, but increases DCS risk. Sounds complicated.
It is a bit tricky. Isobaric means at constant pressure. Counterdiffusion means gases moving in opposite directions across a tissue boundary.
Okay.
So imagine breathing one inert gas, say nitrogen, while another, faster diffusing gas like helium is surrounding you, maybe in your dry suit.
Helium diffuses faster than nitrogen.
Much faster. So the helium could diffuse into your skin faster than the nitrogen diffuses out, causing temporary supersaturation right there in the skin. That's superficial ICD. Causes itching, rashes sometimes, mostly avoided now by inflating suits with breathing gas or argon.
What about deep tissue ICD?
That's more relevant for gas switching on deep dives. Say you switch from a helium-rich mix like trimix to a nitrogen-rich mix like nitrox while still deep.
Helium out, nitrogen in.
Right. Helium leaves tissues fast, nitrogen comes in slower.
Yeah.
This simultaneous movement can, paradoxically, increase the total gas load in some tissues temporarily, raising DCS risk, even if the decompression model says you should be okay.
Why does that happen?
Theories involve different gas solubilities, especially nitrogen and fats under pressure. It's complex. Even switching to air at the surface after a deep helium dive involves ICD. That's why rushing out of the water isn't great. Give things time to stabilize.
And the inner ear is particularly vulnerable.
Seems to be, yeah. Complex anatomy, different tissues, blood supply versus direct diffusion, gas kinetics get messy in there. ICD might be behind some cases of inner ear DCS, which can be hard to treat.
So how do divers manage this risk? Is there a rule of thumb?
There's the 5.1 ratio guideline. Basically, when switching gases, the percentage drop in helium shouldn't be more than 5 times the percentage increase in nitrogen.
A mathematical guideline?
Sort of.
Yeah.
And the trend now is to avoid nitrogen mixes deep anyway, because of narcosis. Many CCR divers just stay on helium mixes all the way up. Open circuit divers might still need to switch due to gas limits.
But these rules are more theoretical.
Largely based on observation and anecdotal evidence, yeah. Individual susceptibility varies. It's an area where there's still more to learn.
Okay, CNS oxygen toxicity, the Paul Bird effect, the immediate convulsive kind.
Exactly. The big worry with high PO2. Rebreather divers with high set points, tech divers breathing the wrong deco gas too deep. That's the risk.
And the symptoms, you mentioned convented.
Yeah, it's a mnemonic. Convulsions, visual disturbances, tunnel vision, blurring, euphoria or anxiety, ear ringing tinnitus, nausea, twitching, especially face fingers, irritability, dizziness.
Convulsions underwater being the absolute worst case.
Lethal, usually due to drowning. Many factors increase the risk. Higher PO2, longer time, being in water, exertion, CO2 buildup, being cold, even some medical conditions.
Can you predict it?
Not reliably in humans. There was a study suggesting rats breathe faster just before a seizure, but that's not practical for divers.
What's the in-water treatment for a seizure?
If you can, keep their regulator or mask in place, hold them at depth till it passes, then ascend directly. If they lose the airway, immediate ascent, then surface rescue breath SCPR.
And for non-convulsive symptoms?
Alert buddy immediately. Switch to a lower O2 gas if possible. Ascend controllably but quickly. Be ready for a convulsion. Surface O2, consider recompression.
High-pressure nervous syndrome, HPNS. Is this relevant outside super deep commercial diving?
Mostly relevant for extreme depths. Yeah, beyond 300, maybe 400 feet. But as tech divers push deeper on helium mixes, they might encounter mild forms.
What are the symptoms?
Tremors, nausea, maybe dizziness, EEG changes, sometimes called helium willies, difficulty concentrating, feeling mentally foggy or agitated.
What causes it?
Poorly understood. Related to pressure effects on nerve cell membranes. Adding some nitrogen back into the mix, making trimix instead of pure heliox, seems to help push the onset deeper.
So slow down descent or abort the dive if symptoms appear.
That's the advice, yeah. Manage compression rate, and use nitrogen in the mix for very deep dives.
Back pain. Seems mundane, but I guess heavy gear makes it worse.
For sure. All that weight, especially double tanks or a rebreather sitting
Mm.
high in the back, can aggravate existing problems or cause new strain.
What can divers do?
The usual stuff. Warm up, stretch, good posture in and out of the water. Lift properly, knees, not back. Keep gear close, no twisting. Proper weighting is huge, too. Don't be overweighted.
And core strength helps.
Definitely. A strong core supports the back. Also, making sure the BCD waist strap takes most of the weight onto the hips, not the shoulders. Using trim weights correctly helps maintain horizontal posture, reducing strain.
And side mount is becoming more popular partly for this reason.
Yeah, takes the weight off the spine, easier to handle gear. Treatment is standard. Once you rule out DCS, prevention is about fit, technique, and conditioning.
Last one. Compression arthralgia, Smithers. Joint clicks and pain at depth.
Yeah, that's it. Clicking, popping, sometimes actual joint pain, usually below 200 feet or so, especially on helium dives.
Why helium?
Well, clicks were noted on old air dives, but less pain reported. Maybe the nitrogen narcosis masked it. Heliox dives definitely brought reports of pain. Shoulders, knees, wrists, hips often affected.
What's thought to cause it?
Maybe just the pressure itself, or maybe inert gas dissolving causes fluid shifts in the joint cartilage, dehydrates the synovial fluid, increases friction. Fast compression can make it worse, but sometimes slow compression does too.
Let's go away.
Usually eases off during the dive, especially on ascent or with longer bottom time. Some divers report lingering aches after surfacing, though. Important to know it's not DCS, it won't respond to recompression.
How to avoid it?
Slower compression rates might help. Spending more time at depth might allow tissues to adapt. Limiting fast, repetitive joint movements deep down is probably wise too.
Well, that's a really comprehensive tour of the specific challenges technical and rebreather divers face. It's way beyond standard diving concerns.
It really is. Understanding these specific issues is absolutely crucial for anyone pushing those boundaries. It highlights how complex the body's reaction is to pressure and altered breathing gases.
You really get a sense of the knowledge and discipline required.
Okay.
I was struck by how something like packing a scrubber correctly is so critical. What stood out to you?
For me, it's often the interplay between factors, like how CO2 makes narcosis worse or increases O2 toxicity risk. You have to see the whole picture, the diver, the gear, the environment.
Well, this deep dive has definitely given us, and you listening, a valuable shortcut into this world. But it is just an introduction.
Absolutely. If you're seriously interested in technical diving or any of these conditions, you need proper training, more in-depth resources, talk to experienced instructors.
And maybe a final thought to leave you with. Think about how studying human limits in these extreme underwater environments teaches us about our own physiology, our resilience.
And perhaps pushes innovation not just for diving, but for medicine and surviving in other challenging places too. It's a fascinating intersection.